Hello there everybody, and welcome to Internal Medicine Pre-Round's Evidence-Based Review. In this video, we will be talking about upper gastrointestinal bleeding. Upper gastrointestinal bleeding is a very important topic to understand for the boards as well as for everyday practice as a hospitalist. First, let's talk about the prevalence. Epidemiological studies suggest that there are approximately 100 to 150 cases of upper GI bleeding for every 100,000 people in the United States. This makes upper GI bleeding a very common condition. When we take a further look at the demographics, we find that older adults, particularly those over the age of 60, are at the greatest risk for any kind of GI bleeding. This is not only because older adults have higher rates of anticoagulant and antithrombotic use, but also because older adults have higher risk of chronic conditions associated with increased risk of upper GI bleeds, such as peptic ulcer disease, GERD, alcohol, and tobacco use. This age group is particularly vulnerable, making it crucial for healthcare providers to be aware of the signs and symptoms of upper GI bleed early on. Now let's discuss the mortality rate. Unfortunately, upper GI bleeds have a mortality rate ranging from 5 to 10%. When compared to lower GI bleeds, which have a mortality of anywhere between 2 to 5%, we see that upper GI bleeds are a more serious condition and have at least twice the mortality rate when compared to lower GI bleeds. These statistics highlight the seriousness of this condition and underscores the importance of prompt medical intervention for all adults with GI bleeding. Lastly, it's important to note that upper GI bleeds account for approximately 2 to 5% of all emergency room visits. This gives us an understanding of how frequently these cases present in the urgent care settings and the need for prompt diagnosis and management. So let's get into the definition. Here we will define what constitutes an upper GI bleed. An upper GI bleed is identified as any bleeding that occurs from any portion of the gastrointestinal tract that is proximal or that is before the ligament of Treitz. This ligament serves as an important anatomical landmark in the digestive system. On the other hand, if bleeding occurs distal or that is after the ligament of Treitz, then it is classified as a lower GI bleed. As we mentioned earlier, lower GI bleeds have a lower mortality than upper GI bleeds and are overall considered a less serious condition. Now let's talk about the ligament of Treitz. The ligament of Treitz, also known as the suspensory ligament of the duodenum, is a fibromuscular band that connects the duodenum, that is the first part of the small intestine, to the diaphragm. It is located at the junction where the duodenum meets the jejunum, which is the second part of the small intestine. This ligament plays a crucial role in maintaining the position of the duodenum, allowing it to remain suspended in the abdominal cavity. Now, why is this structure significant in the context of GI bleeds? The ligament of Treitz has traditionally served as an important anatomical landmark that helps us differentiate between upper and lower gastrointestinal bleeding. As we discussed earlier, bleeding that occurs proximal or before the ligament is classified as an upper GI bleed, whereas bleeding that occurs distal or after is considered a lower GI bleed. Understanding this distinction is vital for clinicians when evaluating a patient with gastrointestinal bleeding. It helps guide diagnostic testing and treatment options, as the causes and management strategies can differ significantly between upper and lower GI bleeds. Now let's discuss the presentation of upper GI bleeds. Recognizing the signs and symptoms is essential for timely diagnosis and treatment. First, we have melena. Melena refers to black, tarry stools. This occurs when blood is digested as it passes through the gastrointestinal tract, which indicates a bleeding source in the upper GI region. Another manifestation of upper GI bleeds is coffee ground emesis. This term describes vomit that resembles coffee grounds, again indicating that blood has been partially digested, suggesting bleeding from the upper GI tract. In cases of significant bleeding, you may also encounter hematochezia, which is defined as the passage of bright red blood per rectum. This can occur in large volume upper GI bleeds where blood may rapidly pass through the intestines without being fully digested. Other important clinical factors to watch for include tachycardia or an increase in heart rate, as well as hypotension, which is defined as low blood pressure. Both of these signs can indicate that the body is responding to significant blood loss. Finally, patients may also experience abdominal pain. The symptom can vary in intensity and may be related to the underlying pathology or cause of the bleeding. It is also important to know that not every GI bleed is accompanied with abdominal pain. In summary, the presentation of an upper GI bleed can include melena, coffee ground emesis, hematochezia, tachycardia, hypotension, as well as abdominal pain. Recognizing these symptoms is vital for immediate medical intervention. Now let's delve into the etiology of upper GI bleeds. Understanding the underlying causes is essential for effective diagnosis and prompt treatment. First on our list is peptic ulcer disease. This condition involves the formation of sores on the lining of the stomach or the first part of the small intestine, often due to the action of stomach acid. Peptic ulcers are a leading cause of upper GI bleeding in the United States. Next, we have gastric varices. These are enlarged veins in the stomach as well as distal esophagus, which typically result from increased pressure in the portal vein, often due to underlying liver cirrhosis. When these veins rupture, they can lead to significant upper gastrointestinal bleeding. Another potential cause is angiodysplasia. This refers to abnormal blood vessels in the gastrointestinal tract which can become fragile and bleed. This can be a contributor to upper GI hemorrhages. Moving on, we also have Mallory-Weiss tears. These are lacerations in the mucosal lining of the esophagus or stomach that occur due to severe vomiting or retching. These tears can lead to noticeable bleeding and require prompt medical intervention. We also have tumors. Whether benign or malignant, both can be sources of upper GI bleeding. These growths may invade blood vessels or cause ulceration, which can lead to significant upper GI bleeding. Lastly, we have perforations of the gastrointestinal tract, which may occur due to conditions such as peptic ulcers or trauma. This can also result in significant upper GI bleeding and is oftentimes considered a surgical emergency. In summary, the etiology of upper GI bleeds encompasses a range of conditions including peptic ulcer disease, gastric varices, angiodysplasia, Mallory-Weiss tears, tumors, and perforations. Recognizing these causes is crucial for effective management and treatment of patients with upper gastrointestinal bleeding. Okay, so let's move on. In this section, we will explore the key historical factors that are important when evaluating a patient with an upper gastrointestinal bleed. First, let's consider NSAID use, or nonsteroidal anti-inflammatory drugs. Nonsteroidal anti-inflammatory drugs are commonly used for pain and inflammation but can irritate the stomach lining, increasing the risk of bleeding, especially with prolonged use or high doses. Next, we have anticoagulant use. These medications like warfarin or newer oral anticoagulants are designed to prevent blood clots but can also heighten the risk of bleeding, including in the gastrointestinal tract. It's crucial to determine if a patient is taking these drugs as part of your initial evaluation for an upper gastrointestinal bleed. Other medications to evaluate for include antiplatelet drugs such as aspirin and clopidogrel, which can also play a significant role. These drugs inhibit platelet function, which can prolong bleeding times and increase the likelihood of an upper GI bleed. A history of H. pylori infection is another important factor. This bacterium is notorious for causing peptic ulcers, which can lead to bleeding. Next, liver disease should also be considered. Conditions like cirrhosis can lead to complications such as portal hypertension and gastroesophageal varices, which are common sources of upper GI bleeding. Finally, lifestyle factors such as alcohol or tobacco use can significantly impact the risk of upper GI bleeds. Excessive alcohol use can cause gastritis and ulcers, while tobacco can exacerbate these conditions and impede wound healing. In summary, when assessing a patient with an upper GI bleed, it's vital to take a thorough history that includes NSAID use, anticoagulant and antiplatelet medication use, history of H. pylori infection, history of liver disease, as well as lifestyle habits like alcohol and tobacco use. Understanding these factors can help tailor the management and treatment approach for each patient with an upper GI bleed. Now let's discuss the key physical exam findings associated with upper GI bleeds, which can provide valuable insights into the severity of the condition. Firstly, let's examine the signs associated with varying degrees of blood loss. With less than 15% total blood loss, you might observe resting tachycardia. This is the initial body's compensation to maintain cardiac output despite the reduced effective circulatory volume. As blood loss increases to 15 to 40%, patients may exhibit orthostatic hypotension along with tachycardia. This occurs when a patient experiences a drop in blood pressure upon standing, indicating more significant blood volume depletion. In cases of more than 40% total blood loss, you may notice supine hypotension and tachycardia. At this stage, even lying down, the patient's blood pressure remains low, reflecting severe hypovolemia. Additionally, a positive blood on rectal exam can indicate the presence of blood in the gastrointestinal tract, although it is not always reliable in determining the source of an upper GI bleed and is not universally recommended. Abdominal pain is another critical finding that can suggest specific causes of upper GI bleeding, such as perforation or peptic ulcer disease. The presence and nature of pain can guide further diagnostic evaluation. Lastly, the presence of bloody stools can vary. While melena is more typical of upper GI bleeds, the exact presentation can depend on the bleed's rate and location. As we had mentioned earlier, patients with high rate, high volume upper GI bleeds can present with hematochezia or bright red blood per rectum, but this is not always the case, especially in patients with less severe upper GI bleeds. In conclusion, the physical exam in cases of upper gastrointestinal bleeding can reveal a variety of signs, including resting tachycardia, orthostatic hypotension, supine hypotension, positive blood and rectal exam, abdominal pain, and possibly bloody stools. Recognizing these signs helps assess the severity of blood loss and guides further management. Now let's explore how we diagnose an upper GI bleed by examining key clinical indicators and laboratory findings. First, consider the history of coffee ground emesis or melena. Patients may report vomiting material that resembles coffee grounds, indicating partially digested blood or passing black tarry stools known as melena. These are classic signs of an upper GI bleed. Next, observe for hemodynamic changes. Tachycardia and hypotension can indicate significant blood loss as the body attempts to maintain circulation with a reduced blood volume. These changes are crucial for assessing the severity of the bleed. Abdominal pain can be another important symptom. Although not always present, pain might suggest specific causes such as peptic ulcers or perforation. The presence of blood in the stool can vary. While it might not always be obvious, any trace could support a diagnosis of GI bleeding. Additionally, the BUN creatinine ratio can be a useful diagnostic clue. A ratio greater than 30 is often seen in upper GI bleeding due to increased urea production from the digestion of blood proteins. In summary, diagnosing an upper GI bleed involves a combination of patient history, observing clinical signs like coffee ground emesis or melena, hemodynamic changes, abdominal pain, and laboratory findings such as blood in the stool, low hemoglobin, and an elevated BUN to creatinine ratio. Together, these elements help guide the diagnostic process and subsequent management of an upper GI bleed. Now let's move on to the essential steps for managing an acute upper GI bleed, focusing on initial stabilization and treatment. First and foremost, establish intravenous access. It is crucial to use large bore IVs or a central line to facilitate rapid fluid resuscitation and medication administration. Next, it's important to obtain necessary labs. Key tests include a complete blood count to assess hemoglobin levels as well as platelet levels, a comprehensive metabolic panel to evaluate for metabolic function as well as underlying metabolic complications, an INR to check coagulation status, troponins to rule out cardiac involvement, and a type and cross to prepare for potential blood transfusion. Ensure the patient is NPO, that is nothing per oral, to prepare for possible procedures like endoscopy and to prevent further complications from gastrointestinal bleeding. It is essential to assess hemodynamics regularly to monitor the patient's cardiovascular status. This involves continuous assessments of heart rate, blood pressure, and other vital signs to ensure adequate perfusion. Correct coagulopathies or thrombocytopenias whenever appropriate and if present. Administer appropriate blood products or medications to manage bleeding risks such as vitamin K, fresh frozen plasma, or platelets as needed. Initiate treatment with a proton pump inhibitor. These medications reduce gastric acid production and can help stabilize the gastric environment and promote clot formation. These medications have also been shown to decrease complications related to upper gastrointestinal bleeds. Finally, it is extremely important to obtain a formal gastroenterology consult for possible endoscopic evaluation. An endoscopy should ideally be performed within the first 24 hours in patients with active gastrointestinal bleeding to identify and address the source of bleeding. In summary, managing an upper GI bleed involves several critical steps, such as establishing intravenous access, obtaining key labs, keeping the patient NPO, monitoring hemodynamics, correcting coagulopathies whenever appropriate, administering a proton pump inhibitor, and consulting a gastroenterologist for endoscopy. These measures help stabilize the patient and address the underlying cause of bleeding. Now let's turn our attention to the management strategies for upper GI bleeds. Blood transfusions play a crucial role in the management of upper gastrointestinal bleeds. There are generally two indications for blood transfusions in upper GI bleeds, and these include the presence of hemodynamic instability or the presence of severe anemia. Let's begin with the first one of these, which is hemodynamic instability. Hemodynamic instability is defined as a blood pressure of 90 over 60 millimeters of mercury or less. That is, if a patient has a blood pressure of 90 over 60 millimeters or less, then they are considered to be hemodynamically unstable. In these patients, transfusion with packed red blood cells is appropriate. Rapid transfusion is essential to restore blood volume and improve oxygen delivery to tissues. You can also administer fluid boluses while waiting for blood transfusion. This helps maintain blood pressure and perfusion until blood products are available. Ideally, isotonic solutions like normal saline or lactated Ringer should be used, and patients should be transfused no more than 1 liter of crystalloids prior to initiation of blood transfusion. Now let's talk about if the patient is hemodynamically stable. That is, if their systolic blood pressure is greater than 90 and diastolic blood pressure is greater than 60 millimeters of mercury. In these patients, a CBC should be checked every 12 hours to monitor hemoglobin levels and assess the ongoing need for intervention. If the hemoglobin drops below 7 grams per deciliter, then these patients should be transfused with packed red blood cells. This threshold helps ensure adequate oxygenation and is particularly important in patients with comorbidities or those at risk for further decompensation. In summary, the management of an upper GI bleed involves careful assessment of hemodynamic stability. For unstable patients, prioritize rapid transfusion and fluid resuscitation. For stable patients, monitor hemoglobin closely and transfuse as needed. These steps are critical in stabilizing the patient and preventing further complications. Now let's discuss tailored transfusion strategies for patients with upper GI bleed and history of cardiac illness. For patients with a history of coronary artery disease, transfuse to a goal hemoglobin of 8 grams per deciliter. Patients with coronary artery disease are at a higher risk of cardiac ischemia due to decreased oxygen carrying capacity, so maintaining a slightly higher hemoglobin level is important to ensure adequate myocardial oxygen supply. For patients without a history of coronary artery disease, transfuse to a goal hemoglobin of 7 grams per deciliter or more. In the absence of cardiac disease, a lower transfusion threshold is generally sufficient to maintain adequate tissue oxygenation and is supported by current guidelines to minimize unnecessary transfusions. To summarize, managing an upper GI bleed involves considering the patient's cardiac history when determining transfusion goals. Aim for a hemoglobin level of 8 grams per deciliter in patients with coronary artery disease to reduce the risk of cardiac complications, and a level of 7 grams per deciliter for those without coronary artery disease to provide safe and effective care. Let's review the evidence on transfusion strategies in patients with upper GI bleeds, focusing on whether a restrictive transfusion strategy improves survival compared to a liberal transfusion approach. So let's look at the PICO question. In patients with upper gastrointestinal bleeding, does a restrictive transfusion strategy defined as goal hemoglobin of greater than 7 grams per deciliter improve survival compared to a liberal transfusion strategy compared to goal hemoglobin of 9 grams per deciliter or greater? Evidence supporting a restrictive strategy includes a study by Villanueva et al. Published in the New England Journal of Medicine in 2013. This randomized controlled trial found that patients managed with a restrictive transfusion strategy had improved survival outcomes. The hazard ratio was 0.55 with a 95% confidence interval between 0.33 and 0.92, indicating a significant survival benefit for the restrictive approach. Another study by Wang et al., published in the World Journal of Gastroenterology in 2013, this meta-analysis further supports these findings, showing a similar benefit with a restrictive strategy. The study reported a hazard ratio of 0.52 with a 95% confidence interval between 0.31 and 0.87, reinforcing the survival advantage of maintaining a lower transfusion threshold. In conclusion, evidence from both a randomized controlled trial and a large meta-analysis suggests that a restrictive transfusion strategy targeting a hemoglobin level above 7 grams per deciliter is associated with improved survival in patients with upper GI bleeds compared to a more liberal strategy with a higher hemoglobin target. Now let's review the guidelines from the American College of Gastroenterology regarding transfusion strategies for upper GI bleeds, which reflect the findings from these landmark studies. The American College of Gastroenterology recommends a restrictive transfusion policy for patients with an upper GI bleed targeting a hemoglobin level of 7 grams per deciliter or greater. The key reasons for this recommendation are lower mortality. Studies show that a restrictive transfusion threshold is associated with decreased mortality, contributing to better overall patient outcomes. Additionally, reduced risk of rebleeding. Maintaining a lower hemoglobin target minimizes the risk of rebleeding, which is crucial for patient stabilization and recovery. Finally, fewer transfusion reactions. By reducing unnecessary transfusions, patients experience fewer transfusion-related complications, enhancing safety and comfort. These guidelines are grounded in evidence that supports the advantage of a restrictive transfusion approach, emphasizing improved survival rates, reduced complications, and enhanced patient care. In this section, we'll address the management of anticoagulation in patients experiencing an acute upper GI bleed. Generally, anticoagulants should be stopped. For patients currently on anticoagulant therapy, it is crucial to discontinue these medications immediately to reduce the risk of further bleeding. A consideration to reversing these agents should be made. In cases of severe or ongoing bleeding, consider reversing the effects of anticoagulation. This may involve using specific reversal agents or interventions depending on the type of anticoagulant the patient is taking. However, in general, there is no need to reverse anticoagulants unless the patient is experiencing acute life-threatening bleeding. INR should be corrected. Aim to correct the INR to a level greater than 2.5 prior to performing an endoscopy if feasible. This step helps minimize bleeding risk during the procedure and ensures a safer examination environment. These steps are essential in managing anticoagulation during an upper GI bleed, as they help stabilize the patient and prepare them for further diagnostic and therapeutic interventions. Now let's focus our discussion towards considerations for patients taking antiplatelet therapy as well as patients with thrombocytopenia. First, let's talk about patients on dual antiplatelet therapy, which is often used for secondary prevention of cardiovascular events as well as in patients who underwent recent coronary artery procedures. In such cases, it is generally recommended to continue aspirin monotherapy. This helps in maintaining some level of cardiovascular protection while managing the GI bleed. On the other hand, for patients taking aspirin for primary prevention, the situation is different. It's advisable to discontinue aspirin therapy in these cases as the risks often outweigh the benefits when an active upper GI bleed is present. Lastly, we need to address thrombocytopenia, a condition characterized by low platelet counts, which can complicate GI bleeding. It's important to correct thrombocytopenia, ensuring the platelet count is at least above 50,000, especially in patients with an active upper GI bleed. This step is crucial in promoting hemostasis and reducing bleeding risks. By understanding these management strategies, we can better support our patients through the complexities of upper gastrointestinal bleeds. Now let's dive into the role of proton pump inhibitor therapy in managing upper GI bleeds, particularly following an endoscopic intervention for bleeding ulcers. According to the American College of Gastroenterology, there is a strong recommendation to initiate PPI therapy with twice-daily dosing schedule. This approach is advised after a successful endoscopic intervention has been performed on a bleeding ulcer. Administering PPIs in this manner helps in reducing stomach acid production, which is crucial for promoting healing and preventing further bleeding. It's important to continue this PPI therapy for at least 2 weeks following the procedure. This duration ensures that the ulcer has adequate time to heal and that the risk of rebleeding is minimized. By adhering to these guidelines, we can significantly improve the outcome for patients recovering from upper GI bleeds. Now let's explore the evidence concerning proton pump inhibitor therapy in the context of upper GI bleeding, especially looking at its impact on mortality rates. To address this, we consider the PICO question. In patients with upper GI bleeding, does PPI therapy decrease mortality compared to no PPI therapy? According to a study by Leontadis and colleagues published in the Mayo Clinic Proceedings in 2007, the answer appears to be no. The odds ratio reported was at 1.01 with a 95 confidence interval spanning 0.74 to 1.40. This suggests that PPI therapy does not significantly decrease mortality when compared to no PPI therapy in patients with upper GI bleeds. Now let's examine the effect of PPI therapy on the risk of rebleeding in patients with upper gastrointestinal bleeding. To investigate this, we consider the following PICO question. In patients with upper gastrointestinal bleeding, does PPI therapy decrease the risk of rebleeding compared to no PPI therapy? The evidence suggests a positive outcome. According to the same study by Leontides et al. Published in the Mayo Clinic Proceedings in 2007, PPI therapy does indeed reduce the risk of rebleeding in patients with ulcer-associated gastrointestinal bleeding. The study represents an odds ratio of 0.49 with a 95 confidence interval ranging from 0.37 to 0.65, indicating a significant reduction in rebleeding risk for those receiving PPI therapy after an ulcer-related gastrointestinal bleed. These results highlight the importance of incorporating PPI therapy in the management strategy for patients with gastric ulcer-associated upper gastrointestinal bleeding, as it plays a crucial role in reducing the likelihood of rebleeding and improving patient outcomes. Let's further explore the impact of proton pump inhibitor therapy, focusing on its effect on the need for repeat endoscopy in patients with upper GI bleeding. Our pico question here is, in patients with upper gastrointestinal bleeding, does PPI therapy decrease the risk of requiring a repeat endoscopy compared to no PPI therapy? According to the same study by Leontides et al. Published in the Mayo Clinic Proceedings in 2007, PPI therapy significantly reduces the risk of repeat endoscopy. The odds ratio reported is 0.32 with a 95% confidence interval between 0.20 and 0.51. This indicates that patients receiving PPI therapy are substantially less likely to need a repeat endoscopy. This evidence underscores the effectiveness of PPI therapy in managing upper gastrointestinal bleeding, as it not only aids in reducing rebleeding but also decreases the necessity for additional endoscopic procedures. By incorporating PPI therapy into treatment regimens, we can improve patient care and reduce the burden of repeat interventions. Before we wrap up our discussion on upper GI bleeds, we need to discuss the management of upper GI bleeds in patients with cirrhosis, a group that requires special considerations due to their unique risk factor profile and altered physiology. For patients with cirrhosis who present with an upper gastrointestinal bleed, it's crucial to initiate prophylactic antibiotic therapy prior to endoscopy and as soon as possible. This approach is important because these patients are at higher risk of developing infections, which can complicate their condition and worsen their outcomes. The recommended antibiotics for this prophylaxis are ceftriaxone or ciprofloxacin. Starting this treatment early helps in reducing the risk of infections such as spontaneous bacterial peritonitis, which can occur in the setting of a gastrointestinal bleed. It's important to complete a 70 course of antibiotics to ensure adequate protection against potential infections. By following this protocol, we can significantly improve the prognosis for cirrhotic patients experiencing an upper gastrointestinal bleed, enhancing their chances of recovery and preventing further complications such as spontaneous bacterial peritonitis. Let's finish off by reviewing the Society Guidelines for Managing Upper GI Bleeds in Cirrhosis Patients as outlined by the American College of Gastroenterology. According to the ACG, the use of short-term prophylactic antibiotics in patients with cirrhosis who experience a gastrointestinal hemorrhage is crucial. This recommendation applies to patients with or without ascites. The evidence suggests that administering these antibiotics not only decreases the rate of bacterial infections but also significantly increases survival rates. Given these benefits, short-term antibiotic prophylaxis is considered standard practice in all patients with cirrhosis and acute variceal hemorrhage. By adhering to these guidelines, healthcare providers can enhance patient outcomes, reduce infection-related complications, and ultimately improve survival in this vulnerable population. This approach highlights the importance of integrating prophylactic antibiotics into the treatment regimen for cirrhotic patients with gastrointestinal bleeding, ensuring comprehensive and effective care. Thank you so much for watching. For a full list of references, please check the video description. If you liked this video, please like and subscribe. Stay tuned for the next one.